Good afternoon, everyone. Happy October. Welcome to Office Hours. I want to thank you all for joining today. I know there's been some trainings going on out there in the field, so some folks who normally can attend may not be here today. So, for those of you who are, thank you very much. I'm going to start clicking along here, get us rolling. As always, we're recording this session, so if anybody has anything they want to reflect back on, we'll have that up on our website in the near future. And if there's questions along the way, please feel free to unmute and ask or put something in the chat. With that, I'm just going to verify that the deck is up in view for folks and they can see the chat as well. All right, good. We had a little technical difficulty earlier, so I'm glad it's working. All right, normal policy and procedure update. We actually have quite a few this month that Jessica is going to touch on, some children's updates as well. An update for NetSmart.
Okay, again, I'm not hearing anything. What do I do here?
Hello? Can folks hear? All right, well, I'm going to keep on going. I'm hearing yes through the chat. And then we'll do a touch on the CES tool, appropriateness criterion for health home, the PCS survey, as well as just an update where we're at with our Omega audit through the lead health home. So that's kind of how our role is going to go today. And with that, going to go ahead and move into our policy slide. You'll see here there's a number of updates, as I had mentioned, that we're going to walk through. And all of these policies on the left are also up on our website on the policy webpage. It's just got uploaded the other day. So that's activities and billing protocols for newly referred members, the CANS New York, the disenrollment policy, HCBS rights and choice, the CS transfer, informed consent, plan of care adults and plan of care children, and our systems access policy we'll be touching on momentarily. And then we have a couple more policies that are going to be coming forth in the near future, and that's qualifying conditions and quality performance improvement policy. And as you see, we have our link as always, just for folks to reference in the event you wanted to reference those policies on our webpage. Jessica, you're up.
Can you hear me?
Yes.
Okay, I didn't do a test. I didn't do an audio test first. Yeah, so I just wanted to start with the activities
Makes
and
it
billing
fine. I can
protocols for
hear.
newly referred members. There's no updates to this policy. It was just an annual review. On this slide, I just wanted to put a reminder out there that moving forward, all of our policies are going to include the DOH policy number or the DOH standard, because
If I
not
sit
everything
there.
is based on a policy. Sometimes it's based on a DOH standard. And there is a statement of receipt and that the policies have all been approved by our chief compliance officer moving forward. So no updates to this particular policy, but I just wanted to put a reminder out that all of our policies moving forward will include these updates. You can go to the next slide. CANs. So this was an annual update for our CANs. So we do have a couple of things that we have either updated, clarified, or just wanted to put some written language around. And some of this is based off of some changes that we're seeing with the CANs, some things that we see in audits, some stuff that is going to be on our new redesignation tool for children. So first would be that we're ensuring that we are tying the CAN's strengths and needs into the plan of care. So you'll see on the top of your plan of care where you'll see strengths and barriers, and you have to type in, you know, the member and family strengths and barriers up there. You want to make sure that the strengths and needs directly from the CANs, and you can use the exact verbiage from the CANs. That's where you want to populate that information. So that shows that you're completing your CANs, you're assessing the strengths and needs of the family, and then you're going to tie those directly into the plan of care. The second thing that the Department of Health is going to be looking for when they do our redesignation is they're going to be looking for supporting documentation to support the cans and to support the ratings that we have in the cans. So that's going to be your eligibility documentation. That's going to be your IEP or your 504 from a school. It's going to be any evaluations that you gather. You want to make sure that if you're rating a kid, high for, school academic function, that they or learning disabilities, you want to make sure that we have the supporting documentation that supports those CAN scores. Potentially the biggest change that everyone's going to see in our new policy is that we are asking that the CANs now be completed within 30 days of enrollment. This is actually a new score that's going to be part of our process scores for redesignation. That's going to be a new scoring mechanism that they use is how many of our cans are completed within the first 30 days of enrollment. You still have up to 60 days before billing will cease. But as far as a quality and process, we will be asking that you complete them within the first 30 days. And the other bit of information is if you are accepting a transfer that is a warm handoff, so there is no break in service, your CMA does not have to redo a CANS. You do not have to complete a new CANS. They already have an active CANS. We have spoken to the state on meetings about this, stating that we don't always agree with the assessment or something may have happened. There's a reason for the transfer. So as a new CMA accepts a transferred member, we like to redo the CANS, reassess, look at it ourselves. What they are asking us to do is do all of those things and then reassess if necessary. So what you would do is you would do a early reassessment prior to the due date, because you have new information based off of whatever you learn at your intake for that member. Does anybody have any questions on any of these updates? Okay, we'll go to the next slide. Next is disenrollment. This was an annual update, so there's no changes to policy, but we just wanted to put a few reminders out there. That when you're disenrolling a health home member, you do need to issue in writing on agency letterhead that the member has been disenrolled and that their 50/55 is no longer active. Some members, if they are not in agreement with their disenrollment, or you have not had a conversation with that member about disenrollment, they will still need to be issued the 5235. But either way, we do need to be issuing in writing to the member the reason for disenrollment, that they have been disenrolled, how to re-enroll. And there is a sample letter in our disenrollment policy. Another thing we want to do is make sure that when we're disenrolling people that we're notifying their care team. So whoever makes up their care team, that we just call them, shoot them an email, just let them know that that person has disenrolled from health home care management. And the other thing is we just want to make sure that we have a documented plan in the member's record. That could be using one of our appendix that are in our disenrollment policy. It could be your agency's own disenrollment plan, whatever you guys have that you upload. Could be a thorough note that you guys enter. We just want to make sure that we see some disenrollment planning in there and that something is going to the member. Does anybody have any questions on disenrollment? Okay. HCBS rights and choice. So this policy pertains to children and it pertains to children enrolled in HCBS waiver. There's no changes to this policy. It was an annual review. I just did want to put a couple reminders out there. The freedom of choice form, so that's the 5276, needs to be completed after you complete a level of care and then annually thereafter. So every time you complete a level of care, you need to follow that up with a freedom of choice form. And when you do the initial level of care, it's super important that you review the rights and responsibilities sheet that accompanies the freedom of choice form. This is all in our HCBS toolkit. It needs to be documented in the record that you have reviewed the rights and responsibilities sheet with the member and the family. An easy way to do that is to have them initial the rights and responsibilities sheet and then upload that in the record, put a note in that you have discussed it. They have initialed that it has been reviewed with them. It's not required that that document be uploaded, but it is something that we look for. It's basically an attestation to us that you guys have reviewed that information. This is something that they do look for when we get audited for HCBS. They want to make sure that the families who are enrolled in HCBS waiver know their rights and know their responsibilities. They know how to file a complaint if they are dissatisfied with services. If they suspect abuse by a provider, that they know how to report that. So that is the information that we get audited that they'll be looking for. And all of that information is right on that rights and responsibility sheet. So it's important that we're reviewing that with families and then documenting that we have reviewed that with them. Does anybody have any questions on this slide? Okay, so health home transfers to CS or CS transfers to health home. This is another annual review. The only thing we updated was just some clarification language about what the health home care manager needs to document about a conversation with the family. So what DOH is looking for anytime that they see a transfer to CS or from CS is that the health home care manager is reinforcing the differences between CS and health home. So if you have a member enrolled in health home and they want to disenroll but continue HCBS, you could refer them to CS. They want to see it documented somewhere that you have let that family know that that means that they will no longer have a care manager and that they won't have a single point of contact, and that once they go to CS, the only thing they're going to do is manage their services, nothing outside of that. If you receive a referral from CS, what the DOH is looking for when they audit us is they're going to go in and see that you have reinforced what a health home care manager does versus CS. So now that they're with you, that they understand that they're going to have monthly contact, engage in health home care management services, what we do versus what CS did. So this has always been a requirement. We just wanted to put in some clarifying language around it just to make sure that we have that documented in our record, because the only place to really document this is going to be in a note. So we just want to make sure that the care managers are ensuring that they're having these conversations with the family and that it is documented in the record. Does anybody have any questions on that? Okay. Informed consent. So this is our consent policy. Again, it was an annual update. A couple of things that we want to review is that as we're auditing and as we get audited, it's super important that when you're reviewing any DOH form, not just a consent form, that the entire form is completed in its entirety. So that means every checkbox is checked, everything has a date, everything is signed. If there's a blank space where you need to write a phone number in, that you're making sure that you write that number in, and that the entire form is uploaded into the system. When we get audited, they're looking for a complete correct form completely uploaded. If the form is completed incorrectly or it's missing a page, we do not get credit for that form being there. So we just wanted to really reinforce to take your time with DOH forms and make sure that they are uploaded in its entirety. The other thing that we have been looking at as we audit is, are the consent forms being reviewed with the family, because it is an informed consent, which means that families and members that we enroll really need to be informed about the decisions they're making and what they are signing. By signing our consent forms now for both adults and children, they're also consenting to HCSNE and they're also consenting to psyches. There are ways to, if you have a particular member who wants to enroll in health home, but they would not like to have their information shared on those two or looked at in those two platforms, that's something that we need to know at intake. So we really want to make sure that any member that we enroll is making an informed decision about signing consent. The other thing that we've noticed on a lot of consent forms is on the top, the CMA is listing the CMA agency and not the health home. You want to make sure at the top of the consent forms, the health home is listed, and then in the provider section, that is where you're going to list your CMA. Another thing to point out is that, especially now on the children's side, we've combined the 5200 and the 5201. It's just one form now. It's a 5201. Those two forms are the consent to enroll in health home, and it's also the information sharing consent. So you need the date that that consent form is signed is the date of enrollment. That's the date that they consent to enroll into health home. So your enrollment date needs to match the date on that consent form. Your consent form should never be signed, have a date that's before or after they have enrolled in health home. Also, some of our CMAs use a pre-filled consent form. So that's a consent form that has already been typed into and it already has a list of providers typed in there. That is okay to use. However, if you are going to use a pre-filled consent form, the member must initial individually next to each provider. Initialing at the top means that they consent to everybody on there, which indicates that potentially it was an informed consent if they're just consenting to everybody on there, multiple, SPOAs, multiple providers that provide the same service. You really want to make sure it's individualized to that member. So if it's pre-filled, you're going to initial next to each individual provider. If it's not a provider that they're going to use, then you need to cross that provider out and you need to initial next to it. And lastly, when it comes to consent forms, there is an FAQ document that accompanies the 5201 for children. We really want to make sure that that FAQ is being reviewed with the families, acknowledged by the families when they actually sign the 5201. They are acknowledging that they had the FAQ reviewed with them, but we need to make sure that when we're doing either our intake notes or enrollment notes, whoever your CMA does it, is that you note in that note that the FAQ has been reviewed with the family. Also, another good way to do this, just like that rights and responsibility sheet, is have the family initial, and then you can upload a copy, and it basically shows that they attest that they had that FAQ document reviewed with them. Does anybody have any questions about consent policy?
Yes, this is Tanya from White House. Could you review the initialing of each provider again for us? I'm sorry.
Yeah, no problem. So on a consent form, some of our CMAs, White House is not one of them, Tanya, they will pre-fill a consent form. So that means that they'll list multiple, like DSS is a good example. They'll have like Washington County, Warren County, Saratoga, because they cover those three counties. So they'll list all three. So it's kind of like a reminder when whomever's doing the enrollment, make sure that they get like DSS on the consent form, but we know that that person does not reside in all three counties and they only need to consent to one of those counties. So if they live in Warren County, they're going to initial next to Warren County DSS, and then they would cross a line over Washington County and Saratoga County. So any consent form that is pre-typed in, you want to make sure that it's individualized to that person. Does that make sense?
Yes, it does. Thank you. I was thinking it was more of, when we do the intake call and we pre-fill post intake call with all of the providers that they've identified, that we had to have them initial each one that's applicable on the consent to them. But no, it makes sense. Thank you.
Yep. And so anytime you add or remove, so anytime you add or remove, you're going to draw a line through it. If you're removing it, you're going to initial and date. And then if you're adding, you're going to write that provider in, they're going to initial, you're going to initial, and then you're going to date. On the 5201 for children, you'll notice that there's now an add remove box. That does not exist on the 5055.
Perfect. Thank you.
Jessica, you have a question in the chat. I
Yes.
think you just answered it though, but it's
Yeah,
if you
so
have
when you
provided-
add providers to the 50-55, you'll need to initial next to each of those and date, and as well as the care manager, both when you add somebody on.
Jess, are you saying, this is Sarah, are you saying that if we initial that? So are you saying that if we have 3 different SUD providers in Clinton County and we have one that we checked that the client initialed, then you want us to go in and cross off the other 2?
Yeah, so you're gonna do, so if you list, so you have a member that you have a pre-filled 50-55, you have a member that needs SUD services, you have 3 different providers listed on your 50-55. When you go in to do an informed consent and an enrollment with that member, they're only going to pursue potentially services at 1, maybe 2, because there's a wait list. So you're going to send a referral to both places. But you're going to want to make sure that it indicates that that person has consented to that specific provider. So you want to make sure that they're initialing next to it, and then you're crossing out single line through the ones that they do not want to consent to.
Okay, and on the ones that we're crossing off, do you want both sets of initials also attached to that?
On an initial one, I mean, it's ideal, but you don't have to on an initial, but you will on an update.
Okay, thank you.
And someone is stating that the counties have stopped accepting the 50-55. We have heard this hit or miss at various facilities, not just the county. Sometimes it's specific providers will not accept our consent forms. If you could just send us an email, we can follow up on that. There is a document that DOH developed to send to providers that have stopped accepting the health home consent form.
Yeah, it was a Medicaid update that went out through the state. I want to say the end of 21, possibly end of 22, that addressed this issue, and its language ultimately stating that the 50-55 is a valid consent document and that they should be accepting of that. So we can do that follow-up once you reach out and provide that. We can also provide a link to that document again. I think we've sent it in the past, but it's been a while. A lot of great questions. All right, Jess, anything else on this one?
No, I'm all set. Planning care for adults, annual review. We did update just a couple of things for language clarification, and then a couple of things based off of the new redesignation audit tool. We just want to reinforce that the comprehensive assessment should always be done prior to the plan of care, because we want to see that the needs that are in the comprehensive assessment are incorporated into the plan of care. So when we audit, that's something that we're looking for, that those needs that are in the comprehensive assessment are incorporated into the plan of care. The other piece that we're currently undergoing an iPro audit, so that's for the AIDS Institute. We're undergoing an audit for them right now, but also they have increased their auditing on redesignation around the HIV and AIDS population. So we want to make sure that we're having and looking at greater integration of, if you're serving a member that qualifies under that single qualifying diagnosis, is that we have a good integration of that into the plan of care, and that we're monitoring those members in our plan of care. And we're actually having a care team meeting every 6 months for that population. So if you have a member who's enrolled in health home as for that single qualifying diagnosis of HIV or AIDS, we want to make sure that every 6 months you are touching base with their provider, and then we're monitoring their labs as well, and there's documentation in the record. So that clarification is in this policy, and it is now going to be included in our new auditing tool, because it is going to be in our redesignation. And the other thing we want to focus on, and this is kind of moving forward and it kind of correlates with the appropriateness criteria change, Travis will touch on that later, but it's coming in December, is that we want to make sure that our initial plan of cares and our amendments are really reflective of our members' immediate needs that qualify them for health home, and that our plans of care don't just consist of maintenance goals. So we really want to make sure that our plans of care have actionable goals in there, things that need to be accomplished that can move that member towards graduation. It's okay to have maintenance goals in conjunction with addressing those immediate needs, but we don't want to see a plan of care that consists entirely of maintenance goals. Does anybody have any questions on the plan of care for adults? Okay, we can move on. So plan of care for children. So we had an update there. This was an annual review, so there's just a couple of things that we want to point out. Again, for children, just like adults, we're going to see that update to appropriateness criteria. It's an update, but again, Travis will touch on that later. It should fall in line with steps that you already do for eligibility, but we want to make sure that the kids that we're enrolling in health home, we're also supporting the members and families' immediate needs that qualify them for health home. A children's plan of care should also not consist of just maintenance goals. I touched on this earlier when we reviewed the CANs. When you're filling out the strengths and barriers in your plan of care, you really want to tie that back to the CANs. You can use the exact wording in the CANs with the exact score that you came to really support that. A piece of clarification that came out of our HCBS audit was that any child that is 10 or older should be signing their plan of care. So you should have a parent and guardian signature, and then you should also have the child signing as well. The other thing that came out of our HCBS audit, and something that we're seeing on our new redesignation tool, is that as you're completing a safety and crisis plan with a family, and if there are any health or safety risks identified in the comprehensive assessment under that risks section, or you're going through the safety and crisis plan, and you see there are things there that need to be addressed, that we're incorporating that into the plan of care. So we want to make sure that any of those barriers, risks, anything pertaining to health and safety are incorporated into some capacity into the health home plan of care. The other thing is that interdisciplinary team meetings need to be happening at least annually. This is difficult to document in our EHR because it exists basically in a note. And if it's not worded correctly, and I know we've gone over this audit after audit, is that if it's not literally written interdisciplinary team meeting, that we're not getting credit for having these meetings. So what we have done, and it's a tool you do not have to use, but it's being offered, is that there are 2 forms that are attached to the plan of care policy. One, I'm sorry, does someone have a question? No, okay. The 2 forms that we've added in there, again, you don't have to use, but you can use, are a invitation form. So basically this is a form that we're going to send. You can email it to a provider and ask them to be a part of this meeting. It could be in person, it can be virtual, it could just be a call-in number that you're inviting them. So it shows that you are attempting to coordinate their attendance at this care team meeting. Also, if they can't attend, it also contains a feedback form. So right in that form, they'll be able to provide feedback. If they cannot attend, they can send that to you, and then you upload it into the record. There's also going to be a template for the actual interdisciplinary team meeting. So you can fill that out, and then you can upload those into the record as supporting documentation that those meetings have taken place. So those are 2 new appendix that we have put in the plan of care. As of right now, they're going to sit in as an external document in the EHR. Eventually moving forward, we can see if there's something that we can build right into NetSmart to ease the burden of the multiple places of documentation for this. And in Q4, there will be a children's workflow plan of care training. So look out for the invite for that. I'll be sending that out probably in the next couple of weeks. Probably going to do it after Thanksgiving, before Christmas. And then this is something that we'll also have ongoing. So it's going to be a workflow plan of care training that we'll do ongoing. And then the one for adults is also in development. So we'll also be having a workflow plan of care training for adults. Does anybody have any questions on this? Okay. I think it's Taylor's turn.
It's me. Can you hear me?
Yes. Thanks,
Okay.
Jess.
Systems access. There are no changes. This was just an annual update, but just a couple of reminders to please send the system access form whenever you need an activation, deactivation, or a role change. So obviously everybody is sending them in for activations, but a lot of times I'm not receiving them for deactivations. And when I send those annual staff discrepancy charts out, we often find a lot of staff that are no longer with the organizations, but we never received notice to deactivate. So just please, if you have staff leave, send those in so that we can terminate their NetSmart and DataDen access. And then lastly, make sure that the forms are completed in their entirety, including that registration authority signature at the bottom of the form.
Taylor, I wanted to note too that we have to send in a quarterly names list for all people that access our platforms or electronic platforms. It's part of our secure systems protocol requirement. And DOH Privacy and Security, they check the list because they ask us questions just about every quarter on submission. So it is something that gets checked.
Yeah. So we appreciate you sending those in.
Yes, thank you. All right. Thank you, Taylor.
All right, back to me. If anyone has any questions on anything we reviewed through policy, just please email me. I know that was a lot of information. If you have any questions, you can email me. If you want to hop on a call to go over anything, just let me know and I'll be more than happy to do that. I just wanted to quickly run through some children's updates. The first thing being that we did have our HCBS audit exit meeting with the state. It went well. They have not, we do have a corrective action that I had to submit. Some of the things you're seeing in updates and policy are, in that corrective action. They did not review it with us. It was more conversational. So we talked about a lot about what is going well with HCBS, what are the barriers that we see. So a lot of the things that you guys continuously report to me, that's really important to keep doing because all of that information during that meeting is what I gave back to the state. So it was very conversational. We kind of didn't go through the nuts and bolts of HCBS. They really just wanted what's working, what's not. If we could change things, what would we change? So again, any feedback that you have on HCBS as you go through the process, we do appreciate that because we do have a platform to let the state know what is working, what isn't working. There's some things that they can change. There's some things they have to go through CMS to change, but all of that feedback is important and it does get reported. And I just appreciate everyone's support with HCBS because I know it's not an easy program to navigate while working with all the other children on your caseload. CANS 2.0, still keep an eye out for those booster trainings. They will be required by 11:30 in order to move forward assessing children. I have not checked today if they were out. I did check yesterday, and as of yesterday, they were still not up on the site. So I just wanted to put a reminder out there. Third, safety and crisis plans, just to make sure that these are being completed in NetSmart. Moving forward, we are going to be including these into the quality notebook. So when you get your notebook that potentially you have something overdue, or if it's gone into corrective action, we just want to make sure that you're getting those done. As you do the safety and crisis plan, if you have any issues with NetSmart functionality, please report that to me so we can open a ticket. Something that had come up when we were having a conversation with one of our CMAs, which I thought was a great question because it's not really clarified anywhere in policy, is that low acuity kids, they do need monthly care manager notes. So even if you're serving a low acuity kid where you potentially did not have a face-to-face with because it's not required, still monthly for children, it is required that you have a care manager note and that you're addressing the plan of care with that family at least once a month. So I just wanted to make sure that everyone knew that. And if you have any questions on that, please let me know. Last month we reviewed the SAD population and how to make sure that you have all of the proper documentation. If you have a kid enrolled under the SAD single qualifying condition, what do you need to support that eligibility? So I just want to make sure that everyone knows that they do need an attestation for SAD on file within the last 12 months. That's a 12-month determination that needs to be redone every 12 months. And when you're doing your eligibility screen in NetSmart and you click that they're SAD and that's what they're enrolling under, that's going to feed into your children's billing questionnaire. So now it shows the state that we're billing off of that. So they're going to be looking for the supporting documentation that supports your CBQ and it supports that eligibility screen. And again, that attestation form is in our qualifying conditions policy. Some of our kids that do get referred to us are referred with some sort of SED eligibility, specifically in SPOA. If you get a SPOA referral, it will be in there so that you can use. You don't have to use AHI's form. I'm going to call out Citizen Advocates. They have an excellent SED form that they have always used. It is perfect. They can continue to use that. It's just a tool in there instead of developing your own, or if you don't have one, you can use the one that we have. And lastly, on SED, I know it's a bit confusing, so I am developing like a mini training on that. It'll be like 30 minutes where we just walk through eligibility, what documentation to do, and then how to record that in the member's record. Lastly would be IRAMs. I know that everyone has gone through the IRAMs process and completed their put their trainings in there. We want to make sure that everybody who is responsible for doing that for your agency is that they are keeping that up to date. So if you have a member, or I'm sorry, a staff member leave, that they are adding new staff members to that, removing old staff members, making sure we're keeping up on our trainings. And then if you had any staff that was out of compliance with a specific training as you uploaded those staff into the IRAMs, that you make sure that you're following up with those staff to make sure they complete all of those trainings so they're not showing out of compliance. And also in IRAMs, they are targeting in late 2023 to have all HCBS referrals completed through that platform. I did see a demo last Friday. We do have another meeting coming up. They were looking for feedback on that. It did look pretty simple. It's going to be a way for us to electronically track all of our HCBS referrals that we're making and to make sure that the providers are being accountable and either accepting those referrals, waitlisting those referrals, declining them. It'll give direct feedback right back to the care manager as to what happened with their referral, so you guys don't have to be chasing down providers anymore. Does anybody have any questions on children's updates? All right, again, if you have any questions on anything I reviewed, you can give me a phone call, a text, you can email me. If you want to hop on a call to review anything, just let me know.
Thank you, Jessica. That's a heavy month of policy. Normally we don't have this many, as you all know, but thank you for going through them, Jess, and all the good questions that came out. You know where we're at if you need us. All right, Taylor, you're up.
Me again. Okay, so we added, I think Jess sent out an email to the network, but we just wanted to throw this on office hours as well. We have added a question to the comprehensive assessment in NetSmart.
This question applies to the adults and children's program, and it's under the medical section. And it's pertaining to the necessity of durable medical equipment. I can't remember, Jess, which audit this came from, but this was something that we
This-
needed to add.
Yes,
based
this was
on-
on our updated redesignation audit. This has been added to that audit.
Yes, so now we have passed that along to you guys, and it is now a part of the comprehensive assessment. If there's anybody that is utilizing the paper copy of the comp assessment, you know, when you're out and about and don't have internet access for NetSmart, I have also updated the paper copy. It just has not been uploaded to the website yet. So if anybody needs that, feel free to shoot me an email and I can send that over to you.
All right, thank you, Taylor. All right, so the initial appropriateness and the CES tool training has occurred through the state, as everybody knows. There is a slide deck that's been posted by DOH. I have the link here. I'll be sending this link out after today's meeting, along with the email and the slide deck for today's office hours, as well as this link that goes to that eligibility section. I was able to download the actual slide deck for the training itself. So that I'll include into the email out to the network as well. But just know it's there. There should be recording coming shortly. DOH just said they were going to put one of those 3 sessions up. Since all 3 were recorded, they were going to choose the best of the 3, whatever that is. And so you have a few spots to get this information that came from the state when they supply the training for everyone. Here's the form. I just want to again emphasize it's for adults only. It's not children's and adults form for the CES tool, the continued eligibility assessment. And it's not for Health Home Plus. So it's that low and medium acuity membership that's going to be looked at through this tool. You know, the big thing is 11/1 is the go live date on this. I did send out last office hours the Excel document and the PDF of the tool itself. I'll resend that again today, just so folks have that up front in their availability to access. NetSmart is telling us they're having this live in the system as of 11/1 so that we don't have to do an alternate documentation manually. So we should be able to go right into the record itself in NetSmart and enter in there. So that's the goal. They're telling us that's going to happen. We're holding them to it. We actually have a meeting again tomorrow with our rep from NetSmart to talk about that, to ensure that we're on track for that as of 11/1. This tool has to be completed for any new person enrolled 11/1 or thereafter. If it's an existing person already in Health Home, that's an adult. Again, this is for adults that are low and medium acuity. If it's a person already enrolled and they're, let's say, due in December for their annual review, by December 31st, this tool has to be done for that person if they're an existing enrolled member, and then 6 months thereafter for that member. If it's a new person that enrolled on 11/1 of this year, you do that tool, and then you do it again at their next annual review. So you get a 12-month window for that person, and then 6 months thereafter. So it's all in the slide deck. I just want to reiterate it, that those are some key points with this. There's not going to be any billing ramifications yet with this new tool and process, but I'm foreseeing eventually it will be implemented, because this will have to be uploaded into MAP once all said and done. That's hence the reason that it's got to be an electronic health record. It's fast and furious, as everybody knows. State came September, October, they threw the trainings on, and then here we are. So any questions along the way on it? We are going to hold a training once we get policy from the state. We have yet to receive it. We were just told last Friday on a DOH meeting by the director for Health Home that the policy at the state level is under review right now, and it should be coming out in the very near future. So our hope is it's going to come out before November 1. If not, we will likely be doing a training, a special office hours in the early to middle part of November on it, just to recap on everything that the state's brought forward, tie in the policy when we effectively have it, so that we're following the flow of the policy that the state puts out. So we will have a special office hours, just so folks know that. But until then, we're kind of working off from what the training of the state put forth, all the decks and whatnot that were supplied around that, and any questions that people have that we can help to try and troubleshoot in the meantime. You know, December, the health homes have to start uploading from the electronic health records to MAP. So that's got to start happening in December. So the data collection actually starts November 1, as we said. And then as of December, we had to start reporting that to MAP. So that's how they're looking to see that roll out. All the more reason we're pushing NetSmart to make sure that this is up and live by November 1st. Just wanted to pause quick to see if there's any questions anybody had around the actual CES tool itself or next steps. We have Michelle, you're asking, it has to be completed at an initial enrollment for any new member coming in as of 11/1. It's part of any new enrollment as of 11/1, not Health Home Plus though. We are hoping to track this, and Jillian, we are hoping to track this in DataDen eventually once everything's flowing and we're able to actually, pull data from NetSmart once the system's up and flowing. So yes, that is something that we would be looking at trying to create for DataDen for a monitoring tool as well. Should we start uploading it to MAP in November? Well, we're starting to collect the data in November. We're being told by the state and through the training that December is when the uploads to MAP are supposed to start. So that's the directive they're giving at this point. Where will this be found in NetSmart? It's going to be a form that's going to be created in NetSmart itself. So we'll have to get that to the network once we know where it's located in the system. NetSmart has not told us yet where it's going to be located in the system. So we'll have more information on that once we get that. Any other questions around the CES tool at this point? Again, it's a fast and furious thing. I'm apologizing that it's so abrupt and quick, but this is how it's coming out. This is how it's been rolled out. So we're doing what we can to get the transparency of information, and we'll get that special office hours together and out to the network as soon as we get that policy. Anything else on the CES tool itself? I did also want to mention one more thing around it. It's in the slide deck that I'll be sharing. That was the actual deck in the training that the state provided. This tool can be done by a care manager. It can be done by the supervisor or a QA staff. The state is leaving it up, and the health home's going to leave it up to the CMA to decide who's the best person to do that in your own organization. We're not going to dictate to you that your care managers need to be completing this tool. If that's something you decide, then that's your organization's decision. If you want your supervisors to be the sole entity to do that, whomever does the enrollment, the eligibility piece, naturally now when you have that process in your agency, that may be the spot to start that discussion and make that determination. I hope that's helpful for folks.
Hey, Travis,
Yes.
I just want to clarify something because I think it's a little bit confusing.
Yes.
So the CES tool to be completed, yes, it's going to be for newly enrolled members at 11/1, but it's not completed at enrollment. It's completed 12 months after enrollment for those folks that are enrolling 11/1. So it's newly enrolled members will receive it at an annual date. And then the members that we already have enrolled will be having to complete this at their annual date that we have yet to decide how we're going to determine this, probably enrollment date. So as you come into the health home, it's not part of your enrollment. It's going to be at your 1 year mark, but those are the folks that are going to be exactly at 12 months. It's going to be everybody else that's already enrolled that will have to complete this at a staggered pace. Again, once it's built in NetSmart, we can build something in DataDen to kind of give you guys a due date.
Thank you, Jessica.
I hope that clarified. I think there was just some confusion. I was confused. So hopefully that helps. Or I just confused everyone even more.
No, that definitely fixed it for me.
Okay.
Good,
I just
good.
want that DOH policy in my hand. I need a policy.
Yeah. Well, that's one of the reasons we want to have the policy before we train the network, because we don't want to go against what the policy says or not add in what should be in there. I'm just looking back at the slide deck itself because I actually have a copy on the side, and it says new members enrolled on or after 11/1/23 complete 12 months post enrollment. So to Jessica's point, complete every 6 months thereafter. So if a person, the example is given, Hannah is enrolled on 11/7/23, her first CES tool is due 11/30/24, and her 18-month CES tool is due by 5/31/25. So I hope that helps clarify. And this is going to be in the slide deck that I'm going to include. I think it doesn't have a slide number. Oh yeah, it does. It's slide number 23, actually, in that slide deck that the state had for their training. And then they also
Tina has, oh, sorry, Travis, I cut you off.
Oh no, I was just going to say, and it also gives for an existing member some examples of how that timeline goes as well.
Yes, and then to Tina's point, for those existing members, they're stating it has to be done when the annual assessment is due. Again, we're waiting for policy to make the determination as to what the time frame will be, because what they're saying is potentially that you'll enroll a member, you do a comprehensive assessment, but when you go to do this CES tool, you're potentially not going to have to do an annual comprehensive assessment anymore for adults, that this potentially could take the place of that. So we have to see what it says in policy as to whether or not we build the due date for the CES tool based on the annual comprehensive assessment date. We also toyed with doing with the annual plan of care date. However, people will amend their plan of care, so that will change the date for that. So that's why we were thinking the enrollment date. But before we can make a final decision on how we are going to build the report and the due date, we just need to see that policy from DOH. But if you have feedback on how you would like, if we have wiggle room to pick the due date, absolutely give us your feedback on that and what you think would be the easiest for internally for you guys to work out and for your care managers, if we have a say in it.
Yeah, that was the key. If we have wiggle room, we're hopeful that we do, but again, the policy's coming out ultimately at the wire, if not after the fact. So that makes it difficult on a statewide rollout like this. So we share your frustration, clearly. Any other questions around this? I saw Tina said prefer annual assessment date. So thank you, Tina. We'll take that and put that with our pile of feedback that we have if we're able to give it. Anything else on the CES tool? All right, well, thank you for all the questions. Sorry we're not totally clear and transparent on the exact policies because it doesn't exist yet. But we'll definitely keep the information flowing as we get it. And then the timeframes, we talked about that. So here it is again. I won't repeat it since we've talked about it a little bit, but it's in the deck as well for folks to reference. Appropriateness criteria, that's 12/1. So they're giving us another month for that one. The biggest thing here is this is now going to have to be reported as of December to MAP. And, the health homes will be doing that through the upload to MAP. We have our eligibility assessment now that we have within NetSmart that we utilize. We're trying to, and we've talked to NetSmart somewhat about this, utilize that same tool. So since it's something that I was already using in workflow for a lot of folks as they're doing their thing in NetSmart for eligibility, and we want to make sure that that could be adopted so that it can incorporate whatever the requirements are on this appropriateness criterion. So this one's still in process. NetSmart's priority at the moment is the SES tool going live by 11/1, and then the next one's going to be the appropriateness criteria. We're hopeful that this eligibility assessment within NetSmart's going to do what we need, since it's already an existing form in there, and it's just a matter of tweaking that. And then if that documentation is clear in the member's record as they're enrolling, that the criteria is being met, as a risk factor for them to be appropriate for health home services. That's will have billing implications. We're being told as of February of next year, so February 1 of 24. So it is something that's being tracked closer, and the intent behind it, as folks have heard, is to ensure that people, yes, they may have a qualifying condition or two chronic conditions, but are they meeting the eligibility through appropriateness criterion? So that's really an effort for us, for the state, to look at true eligibility for membership as we move forward, that meet high risk or significant risk versus the number of folks that are at that low acuity or medium acuity rate currently, who may not be appropriate as we start in this new process. So that's the appropriateness criteria at this point. I didn't know if there's any questions or thoughts around this. Again, this is just more language from the state saying the why behind it, and what the intent is for potential cost savings, and really looking at enrolling those that are truly eligible through the criterion being met. And just highlights how it might look in MAP once it gets loaded. So we'll give you more information on this one as we get closer. Hopefully the policy will come out, or the guidance around this will come out around the same time as that SES tool guidance and policy, and it'll help us pave our way as far as any workflow change we may have for the network. Any questions, thoughts around this? Just mention again, we're going to do a special office hours once we get that information in place from the state, and ensure that folks have an opportunity to have that attendance, and we'll have that recorded as well. We'll have a deck together for that as well for folks. And one of the big things with the SES tool, if somebody does move toward disenrollment based on the results of the tool, the state's saying at this point that they go through the fair hearing process, which would ultimately be our NOD and fair hearing policy through our health home. That's the response, the reply in that 60-day planning window for disenrollment or discharge. So that's probably going to come with some pushback initially for certain folks out there, and we're well aware of that. But it's something we're going to have to contend with as a community as this whole rollout happens, and better understand, how this policy is really going to be implemented and pushed statewide. And I'm sure there's going to be some adjustments at some point, because it's so fast and furious and new, and happening abruptly, in the sense that, I'm hopeful that there's going to be a relook at this at some point, and a reassessment, because it's going to, I believe, create some bottlenecking down the road with membership and eligibility for folks who really need to have this service, who may not end up having it, and then they end up having to come back into the system, and they're going to be at a higher acuity rate. It's just going to be a different, higher cost factor down the road for the state. But that's just my thought on the side, which I shared vocally here with everybody. But we'll work with you. Please let us know, as Jessica said, any thoughts, suggestions you have along the way with this new rollout. And if we have the ability to advocate, or any wiggle room to advocate on some of this, we'll definitely do that. Next topic was the PCS survey. for this week, October 23rd for 29th. This is for SMH designated population or Health Home Plus folks that are SMI. And it's for any active engagement during the week of this week for those folks. I know we have our coordinators for each of the CMAs that had to get set up prior to this. Folks have done that. Just a reminder how to submit this information and FAQs. If folks have questions, there's a link here that goes to the survey form, the training, and the accessibility on that. We did have a question come up the other day, and we were able to link that person to the PCS unit. So hopefully they got the answer they needed for that. It was a unique question around the person's health home enroll, but they're also seeing through their clinic, and the clinic person, do they have to complete a separate survey? And we didn't have that answer. We reached out to OMH. The contact there wasn't quite sure. So I ended up going back to the PCS unit themselves to get clarification. So that was a unique example that, if folks have those scenarios this week, please reach out and we'll do what we can to at least get you in the right direction to get those things answered. Michelle, do we complete these for people in step down? So you come in contact with them this week. They're Health Home Plus SMI. They're in step down for the 6-month period. It's a good question. I think we're going to have to bump this. I don't want to give you the wrong answer. I think we need to bump this. I'll ask our contact at OMH and see if they feel it's necessary for someone in step down. So I'll be back in touch with you, Michelle, on that. Any other questions or anything around the PCS survey? No. Okay. Omega audit. We're knee deep in it right now. We were told by the audit team during our entrance it could be average 8 to 12 months. That's an average audit for organizations that have been going through. So we're pouring through our first set of SINs that they provided us. I know some of you have had outreach from the health home looking for certain documentation or certain things. Thank you for your help and trying to identify those things and get them back to us or get them uploaded in EHR. We're trying to work diligently, keep the auditors happy where we can, and keep this moving along. 8 to 12 months is a long time frame. I hope we're not that long. We did provide them with all of our policies and procedures and an appendix that goes along with that for the audit time frame for that October 1, 17 through June 30th, 19. The audit team's aware that we transitioned from one electronic health record to another. So there's some transition as far as data flow and whatnot. So we're looking between two systems for things. So it's pretty hectic in that sense as far as pulling things together, looking up stuff. But every Omega audit is. I mean, it's part of it. So we'll keep you posted on anything that comes up that comes along the way that we think that you folks should be aware of. But the biggest thing is we appreciate anything you can do if we do reach out to look into what that inquiry is and help assist if you can. It's much appreciated. And this is just, again, going through the things that they're looking at. They're looking at the complete record for the folks that are identified, any insurance data around Medicare or third party, any transaction ledger type stuff around billing, all folks involved in that person's care. So that goes back to the whole consent thing that Jessica was talking about earlier through the consent policy and completion of forms and accurate, fully completing, initialing every line. is completed, et cetera. This is getting looked at, to ensure that we're justified in the billing for that time frame for that claim or claims for that individual. And that's it. That's all we have for this month. I know it was a lot. That's why we have this hour and a half here in the event we need it. Didn't know if folks had any other questions or anything they want to talk about that we haven't mentioned today.
I actually had a quick question regarding the 50-55 forms.
Okay.
So on initial 50-55s, when you're completing them with a client, is it acceptable to draw an arrow down from the date listed at the top of the third page to kind of denote that that's the date you're using for each of the providers that are initialed for that initial 50-55? Or does there need to be a date next to the initials and next to each provider for the initial one?
Jessica, you want to take that one?
Sure. So that is, so AHI Health Home, we do allow that arrow. So if you complete 50-55, the member initials at the top, you put the date, you drew the line down indicating that AHI Health Home does accept that. If you work with other health homes, they may not. We actually had this discussion in our regional group. It's just a couple of health homes around this area that get together. Other health homes will not accept that. AHI does. So you can do that for AHI, but that may not, if you work with another health home, they may not allow that. They may ask you to initial and date next to each provider.
Okay, thank you.
Great. Any other questions? Anything anybody wanted to mention? All right. Well, as always, thank you all for everything you do every day and appreciate your time today. We'll get those attachments out with the email to the network that I discussed. And I hope you all have a good afternoon. And we'll talk with you soon. Thank you.